Hello, welcome to the Department of Propedeutics of Internal Medicine number 2. Today we have lecture which is devoted to the chief signs and syndromes of anemias, and we also will speak about bleeding disorders in internal diseases. I am VictoriaKhomazjuk, Associate Professor of this department, and let's begin our lecture. So, when we begin to examine the patient with anemia, of course we start from the interviewing and from finding out symptoms. So, these symptoms may be dyspnea on exertion, syncope, anorexia, palpitations, dizziness, nausea, cold intolerance. It may be chest pain like angina pectoris. It may be intermittent claudication, headache, amenorrhea in women, and decrease of libido. And then we proceed with physical or objective examination of our patient. And first of all, we pay attention to the pallor of skin and mucous membranes. And then we check for hypertension and tachycardia, resting or in orthostatic case. And then we proceed with auscultation, and we may hear systolic ejection murmur over the heart area. We can also auscultate the jugular veins, and in some serious cases we can hear so-called venous hum or humming murmur over the jugular veins. And of course we will examine the spleen, and we may find the splenomegaly or history of prior splenectomy, which are specific for chronic hemolytic anemia. So first of all, we look at the skin, at the face of this patient, and see that she is really pale and her lips are pale. This is the patient with B12 anemia, B12 deficiency anemia. Well, we can also notice the pallor of the skin on the hands and on the palms. Here is the hand of a patient with anemia, and near for comparison in the hand of a healthy person. Then we should also check the skin elasticity or turgor. In anemia, the elasticity of the skin may be decreased, and also the skin become dry. Well, so when we speak about anemia, this is a good chance to remind you of the properties of functional murmurs over the heart area, because the murmur in anemia is functional. It is not the result of some organic problems in the heart. The valves and cavities are okay, but we hear the murmur due to changed viscosity of the blood. How to differentiate this functional murmur from the organic murmurs? First of all, in most cases, functional murmurs are systolic. Then they are not permanent, and they may disappear, especially if you treat your patient and hemoglobin increases. The functional murmurs are mostly heard over the pulmonary trunk and less frequently over the heart apex, but not in other points of auscultation. Very rarely these murmurs are heard during the entire system. They are soft and blowing sounds. Such murmurs are not transmitted and not accompanied by the changes of the heart sounds. Well, we proceed with auscultation of the vessels, and here you see auscultation of the jugular vein on the right side, and during this we expect to hear the venous hum, so-called murmur over the veins in anemia. Well, we should also examine the spleen of our patient, and you should remember that it is located in the left upper quadrant of abdomen, and palpation is the most specific for the detecting the enlarged spleen. And if the spleen is palpable at the level of umbilicus, it is suggestive of the hematologic pathology. Percussion is not so sensitive dullness in the left hypochondric area, but can be specific in non-obese patients. Here we see the scheme of percussion of the spleen. We begin percussion along the left mid-axillary line, and we go down from the level of 6 or 7 rib, and at the level of 9th rib we can find dullness due to spleen. And to find out the lower border of the spleen, we should begin to percuss downwards and go up. And at the level of 11th rib, it will be the normal inferior border of the spleen. The distance between superior and inferior borders is near from 4 to 6 centimeters, and it will be transverse diameter of the spleen. To find out the longitudinal size of the spleen, we should begin percussion from the umbilicus and go in this direction. And the anterior border of the spleen dullness may be found 1 or 2 centimeters laterally from the anterior axillary line. We do it at the level of the 10th rib, you understand, because transverse diameter of the spleen in norm is from 9th to 11th rib, so we percuss somewhere in the middle. Well, and we continue percussion along the 10th rib on the back surface of the body, and we find out the posterior border of the spleen. In norm, it should be somewhere between the posterior axillary line and scapular line in this area. And the size, the longitudinal size of the spleen should be in norm from 6 to 8 centimeters. You see here the picture of percussion of the spleen. Now we are checking for the inferior or lower border of the spleen. We percuss in the upward direction until here dullness. Then, of course, we can use palpation of the spleen, and it is bimanual. So we use both hands. The right hand of the examiner is used for palpation, and the left hand fixes the costal arc and ribs. And of course, don't forget to use breathing during palpation. You will go deeply inside during expiration of your patient, and during inspiration you will try to palpate the edge of the spleen as it will go down. Well, one more position for palpation of the spleen. The head of the patient is somewhere here. He is lying on his right side, maybe 45 degrees turned to the right. And also you use both hands for palpation. Right hand is going under the costal arch deeply during expiration, yes, and left hand fixes the ribs and costal arch, and during inspiration you will wait, maybe the edge of the spleen will slide over your fingers. So now we proceed with different types of anemia. There are two main groups of anemia. First of all, according to the cause. First of all, it may be anemia due to blood loss. Then it may be hemolysis anemias. Then anemia is due to deficiencies. And anemia as a result of decreased production of the red blood cells. And also symptoms of anemia are based on the acuity of the drop of hemoglobin. Acute blood loss usually creates rapid onset of symptoms, but slow drop may lead to fewer symptoms. So we begin to speak about anemia of acute blood loss. When it may be the result of trauma, some problems in gastrointestinal tract, menstrual or vaginal loss in women is very often, then urinary tract bleedings, nosebleeds may be also the cause of anemia. And the main findings in the objective examination will be tachycardia and hypertension. And history will help you to find out what was the cause for anemia. And let's look at the example of the blood analysis. In such type of anemia, we see that erythrocytes and hemoglobin are rather low, but the color index show us that this anemia is normochromic. And we see increased amount of reticulocytes, which means that regeneration go on. And we also see a little bit diminished platelets, maybe the result of hemorrhage. And for all kinds of anemia will be specific increase in erythrocyte sedimentation rate. We also can see polychromazia. It depends on erythrocytes. We have a lot of young forms, and that's why the color may be different from pale to very bright. Well, next group of anemia is anemia due to hemolysis and sequestration. And the causes of such anemia may be autoimmune. Then it may be drug-induced. They may be the result of cell membrane disorders. And of course, they may be hereditary, like sickle cell anemia. Then the main sign of such anemia will be splenomegaly, enlargement of the spleen. And splenomegaly may not only be sign, but it may be the cause of hemolysis. And here we see the example of the blood analysis in the hemolytic anemia. Once again, we see low level of erythrocytes and low hemoglobin. And the color index in this case is normal. Anemia is normochromic. And very specific for such anemia is very high amount of reticulocytes. The regeneration is very active. And we also can see a bit increased leukocytes with the shift to the left in the differential count. The amount of bands is increased. These two may be the result of the reaction on the production of hemolysis. And we see high erythrocyte sedimentation rate once more. And we know that erythrocytes are fragile, very fragile. And that is because most of them are microspherocytes. And such shape of the erythrocytes, microspherocytes, are specific for hereditary disease, Minkowski-Shaffer disease. Oh, wow. And of course, the sign of hemolysis and hemolytic anemia will be icterus or jaundice. And first of all, we should pay attention to the sclera and conjunctiva. They are yellowish in hemolytic anemia and hemolytic jaundice. And here we can pay attention to the specific features of the jaundice in hemolysis. First of all, it is rapid progression, sometimes with fever, yellow lemon skin, but without pruritus. No hepatomegaly, gallbladder is not palpable, but always splenomegaly. And in blood, we can find a lot of unconjugated bilirubin or indirect bilirubin. No changes of enzymes in blood. In urine, we can find a lot of urobilinogen and no bilirubin. And of course, the stools will be dark due to large amount of the stercobilinogen. Our next group of anemias are anemias due to deficiencies. And first of all, it is the most spread anemia, the iron deficiency anemia. And very specific for this anemia are spoon nails and pica. What is pica? Pica, it is the name for the sign of perverted taste. The patient readily eats chalk, clay, earth, and coal. The olfaction changes as well. The patient finds pleasure in smelling ether, petrol, and other substances with unpleasant odor. Here we see the picture of spoon nails, or the medical term is koilonychia. And let's look at the blood analysis of the patient with iron deficiency anemia. Of course, we noticed the low level of erythrocytes and hemoglobin. And when we check for color index, we will see that it is decreased very much, and the anemia in iron deficiency will be hypochromic. And you see that regeneration is rather slow, and reticulocytes are not increased so much as hemoglobin is decreased. Then we can notice also high erythrocyte sedimentation rate and specific changes of the red blood cells. It will be anisocytosis, so different size of erythrocytes, and poikilocytosis. It means very many difference in shape of erythrocytes. One more deficiency, which is the cause of anemia, is the deficiency of the vitamin B12. Such anemia is first of all characterized by burning sensation in the tip and edges of the tongue. And the changes of the tongue leads to appearance of the smooth tongue. And this is due to glossitis. And B12 anemia, or another name is megaloblastic anemia, or macrocystic anemia also. So megaloblastic anemias, which are caused by B12 deficiency and folate deficiency. For such anemias, the affection of the nervous system is very specific. So your patient will complain about paresthesias. Yeah? This is due to affection peripheric nervous system. And also for such anemias is specific the affection of the stomach. The patient will have atrophic gastritis and with reduced function of the stomach and low level of the gastric juice. And as a result of this, the patient may complain of diarrhea. Here we can see this famous smooth tan, which is specific for B12 deficiency anemia. And then we can examine the blood analysis of such patient. First of all, we see a very low level of erythrocytes and low level of hemoglobin. But the amount of hemoglobin inside the erythrocyte is rather high. That's why the color index in this anemia is high. It is hyperchromic anemia, the variant of hyperchromic anemia. And we see that no regeneration appears, so this is anemia with very low or even absent regeneration of the red blood cells. Other cells are also decreased. We see low level of platelets, and the leukocytes are also at the lower border of the norm. And we can see as often high erythrocyte sedimentation rate. And we see a lot of changes in erythrocytes. It will be macrocytosis. Then we can find nucleated red blood cells. Do you remember that red blood cells contains no nuclei? But in this anemia, the remains of the nuclei may be found inside of the erythrocytes, such as oval jolly bodies. And also, if we examine neutrophils, we can see their hypersegmentation in their cytoplasm. Oh, wow. And the last group of anemia that we will speak today is anemia of decreased production. Red blood cell morphology, color index are normal in such anemia, but reticulocyte count is low because of decreased production or decreased regeneration. And also marrow damage and decreased erythropoietin production may produce anemia of this type. This bone marrow damage may be the result of some leukemia or cancer, or it may be the result of exposure to drugs, radiation, chemicals, or viruses. Decreased stimulation of erythropoiesis can be the consequence of the inadequate erythropoietin production. First of all, this happens in the renal disease. And let's examine the blood analysis of such patient, and we see the low level of erythrocytes, low level of hemoglobin. This anemia will be normochromic, we said before, and it will be no reticulocytes and no regeneration. And in this particular analysis, we can pay attention to the high level of leukocytes and the high level of the lymphocytes in the differential count, and a very high erythrocyte sedimentation rate. It means that here we see not only anemia, but also here may be present some problems with lymphocytes, maybe lymphocytic leukemia, and this may be the cause of reduction in production of the erythrocytes. Oh, wow. So if we speak about hematologic diseases, we need to mention lymphatic system, of course, not only spleen, but also the lymph nodes. And I'd like to remind you about the main groups of the lymph nodes that should be examined. We begin from the head and neck, and here you see the groups of the palpable lymph nodes there. Then we proceed. Oh, here you may later look for these groups and try to find them at the picture to remind the anatomy of lymphatic system. And once more, I'd like to tell you that you need to compare nodes bilaterally on the both sides. And here is the example of palpated posterior cervical nodes. In normal, they are not palpable. We should then also examine auxiliary nodes, then inguinal nodes, of course. And here are the descriptors of the lymphadenopathy. We need to check, of course, location, then mobility, size, texture, are they soft or firm, and then shape should be rounded in norm, and the size should be not more than 1 centimeter in diameter, and we should check if they are painful or not, and maybe some changes on the skin as a result of inflammation. Oh wow. And the last part of our lecture is devoted to the bleeding disorders in the internal diseases. Oh wow. So there are 3 main groups. Bleeding disorders may result from abnormalities of platelets, abnormalities of the blood vessel walls, and abnormalities of coagulation process. Platelet disorders produce petechial and purpuric skin lesions and bleeding from mucosal surfaces. Coagulation disorders result in ecchymosis, hematomas, mucosal, and recurrent joint bleeding. Joint bleeding is caused hemarthrosis. Wow. And here we see signs and symptoms of bleeding disorders. It may be bleeding from mucous membranes. First of all, it may be gastrointestinal or genitourinary tract. Then it may be epistaxis or nosebleed. And it may be hemoptysis or expectoration of blood. And then it may be some changes on the skin like purpura, petechia, or ecchymosis. It may be bleeding into the joint. It may be deep hematomas under the skin. And it may be even retroperitoneal hemorrhage. So how to distinguish purpura, petechia, and ecchymosis? First of all, by size. Purpura is greater than 0.5 centimeter in diameter, and petechia is less than 0.5 centimeters in diameter, and ecchymosis may be of variable size. All these elements are non-blanchable. What does it mean? When we press on it, the color does not change and don't become as usual color of the skin. Oh well, a few tips how to distinguish platelets versus coagulation disorders. First of all, petechia are specific for platelets disorders. Ecchymosis, hematomas, and hemarthrosis more frequently seen in case of coagulation disorders or low clotting factors. Then bleeding can be seen in either variant. And if something occurs spontaneously or immediately after trauma, mostly it may be problem with platelets. If in delayed manner after trauma, the more is for coagulation abnormalities. Here we see the picture of petechia, small, less than 0.5 centimeters in diameter hemorrhages on the skin. But here we see the example of purpura. The area of these elements is more than 1 centimeter even. And here we see the picture of a patient with ekhymosis. So ekhymosis here are of different shape and size. And this picture shows us gamarthrosis. And we see that the shape that the knee joint is enlarged, its shape is changed, and we receive a lot of blood by the puncture of the cavity of the joint. And here we see the example of the hematoma under the skin of the hand of the patient. Oh, wow. We can also use some simple screening tests to check for the bleeding disorders. First of all, of course, we use platelet count from the blood analysis, and the normal range for platelets is described here. And then we can check bleeding time by Duke method. So the length of bleeding, and the normal bleeding time is from 2 to 4 minutes. We can check also the retraction of the blood clot. Then for coagulation disorders, we can use blood coagulation time by Lee and Y. We can use prothrombin time. Then we can use activated partial thromboplastin time. And we can also use the test to check permeability of the capillaries. To remember, this third group of bleeding disorders is due to the affection of the wall of the vessels. It may be Konchalovsky-Rumpel signs, it may be cupping glass test, and even very simple pinch test. We check how many hemorrhagic spots appears at the site where you pinch after this, or how many of them appear on the skin after applying of the cupping glass or after applying the tourniquet or the cup of the sphygma manometer. Well, thank you for your attention. This is all for today's lecture. I hope that it helped you to know more about hematology and bleeding disorders. Goodbye.